Thank you, everyone. It is now 15 after the hour, and we'll move on to the next session for the morning on zoster vaccines. Dr. Camille Cotton, chair of the work group, will provide an introduction and an overview of today's session. Dr. Cotton, the floor is yours.
Thank you very much. So we will now talk about zoster vaccines, and specifically with a focus on immunocompromised. Next slide, please. Here's a list of all the participants in the herpes zoster working group. And as you can see, we have some ACIP members, ex officio members, liaison representatives, invited consultants, which we really appreciate their input, and most importantly, our CDC lead, Tara Anderson. Next slide, please. Here's the timeline for the recombinant zoster vaccine. FDA licensure happened in October 2017, and then there was CDC subsequently adopted the ACIP recommendation in January 2018. The EMA approved an expanded RZV indication a year ago, August, for adults over the age of 18 at increased risk for zoster. And then supplemental biologics license application was submitted to the FDA in the fall of 2020. We started reviewing this from the ACIP perspective earlier this year. And then as of July, the FDA had approved the expanded RZV indication for use in immunocompromised adults 18 and up. Next slide, please. So the policy question we're facing now is that should adults at least 19 years of age who are or will be immunodeficient or immunosuppressed due to disease or therapy be recommended to receive 2 doses of the recombinant zoster vaccine for the prevention of herpes zoster and its complications? And these groups that are listed here are those who would be considered immunodeficient or immunosuppressed. And it is somewhat of a different group than what many of us have been thinking about with respect to things like COVID-19 vaccines, but basically stem cell transplant recipients, patients with hematologic malignancies, kidney or other solid organ transplant recipients, patients with solid tumor malignancies, people living with HIV, and patients with primary immunodeficiencies, autoimmune conditions, or who are taking immunosuppressive medications or therapies. So that's the major focus groups. Next slide, please. So the PICO question, so looking, the population is immunocompromised adults at least 19 years of age. The intervention is whether they should get 2 doses of recombinant zoster vaccine at least 4 weeks apart. The comparison would be no vaccine. The critical outcomes were both to prevent herpes zoster, but also to prevent or to consider serious adverse events. Important outcomes would be to prevent postherpetic neuralgia, which can be a major complication, to prevent herpes zoster-related hospitalizations, to consider the risk of immune-mediated disease as well as reactogenicity, and to see whether there might be an increased risk of graft versus host disease or graft rejection. Next slide, please. So at the June ACIP meeting, we began to discuss some of these issues in the evidence to recommendation domain, as you can see in yellow. And we have yet more to discuss as shown below. Next slide, please. Since our June meeting, we have had 4 work group meetings and have reviewed and discussed the remaining evidence to recommendation domains, including an economic assessment of the use of this vaccine in immunocompromised patients aged 19 through 49. We've also reviewed data on primary care physicians' perspective related to the vaccine and looked at a great analysis regarding the use of this vaccine in immunocompromised adults. We've also thought about special considerations for potential use of this vaccine in immunocompromised adults. Next slide, please. So in today's session, we will review the economics of vaccinating this population against zoster in the United States and review ongoing evidence to recommendation regarding the use of this vaccine in immunocompromised adults, and then the next steps, and also have discussion. Next slide, please. And I'd just like to acknowledge the tremendous contributions from so many different people, both in the working group, our CDC lead, and then other contributors at the CDC. And it's been an impressive amount of data that has been reviewed to get to this point. Next slide, please. Thanks very much for your attention.
Thank you, Dr. Cotton. I think we can move on to the next presentation by Dr. Nina Masters. I guess we're switching the order. Dr. Wharton, shall we proceed with Dr. Ortega-Sanchez first?
I believe that's the case.
Okay, thank you, Dr. Ortega-Sanchez. The floor is yours.
Thank you, and good morning to everybody. My name is Ismael Ortega-Sanchez. I'm the Senior Economist at the Division of Viral Diseases at CDC. Today, I will talk about the economics of vaccinating immunocompromised adults in the United States against herpes zoster. Specifically, I will intend to summarize key elements and findings of two economic studies, which were discussed in extenso in the ACIP working group. Next slide, please. One of these studies is an in-house economic analysis led by Dr. Andrew Leitner from ISD at CDC. I will refer to this as the CDC model in blue. The second study has been conducted by the GlaxoSmithKline. I will refer to that as the GSK model in light brown. For full disclosure, I have been part for the team conducting the CDC model. Next slide, please. Although the policy question has been particularly motivating for this economic analysis, given how heterogeneous the IC conditions could be, the economic assessment of this potential recommendation is quite challenging. Therefore, the approach adopted in both models was to split the policy question by age, 19 to 49 years, and a specific IC condition. The base case in both models is focused on the hematopoietic stem cell transplant. Next slide, please. To consider the economics of the policy question is to consider simultaneously the health benefits and costs of vaccination, namely, is vaccinating immunocompromised adults against herpes zoster cost effective? To address this question, both models use the same comparator, unvaccinated immunocompromised groups, and focus on the analysis of cost effectiveness of recombinant zoster vaccine immunization in 19 to 49 years adults with hematopoietic stem cell transplant. Next slide, please. In addition to the hematopoietic stem cell transplant recipients, the working group has been considering the economic vaccination of additional immunocompromised populations. Specifically, the CDC and GSK coincide in modeling one another IC population, namely adults living with human immunodeficiency virus. On the other hand, highlighted in blue are the immunocompromised populations or scenarios considered by CDC model, which are different than those groups considered by the GSK model, listed here in light brown. Next slide, please. In general, both models follow similar designs, namely, both models use a static analytical decision-making approach, relying on probabilistic simulation and sensitivity analysis to manage the various data and uncertainties, modeled a hypothetical cohort of 19 to 49 years hematopoietic stem cell transplant recipients, use reasonable time frame analytical horizons and discount rates. A key difference worth to mention here is that the CDC model uses a healthcare perspective, while the GSK model uses a societal perspective. The latter because they accounted for the loss of income associated to temporary productivity loss, while the former, the CDC model, focused only on the direct medical costs. Next slide. Once models were set, they were fed by different types of input data: clinical, epidemiological, economic, quality of life in specific immunocompromised conditions, vaccine characteristics, etc. Across models, the source, specific values, and assumptions of these parameters had some overlaps, but there were marked differences as well. For your consultation, the full reports with the input data and assumptions from both models have been made available to the ACIP members. Back to this slide, in the box are listed the outcomes estimated. Those in black are reported by both models, in blue only by CDC, and in brown only by the GSK. Next slide, please. Before proceeding, I wanted to briefly review a few economic concepts that will help us understand the results better. First is the cost of intervention, which is basically the cost of vaccination program. This includes the cost of recombinant zoster vaccine doses, cost of administration, and cost of associated adverse events weighted by their probabilities. The second concept is savings from intervention, which are changes in cost of illness due to vaccination, yet not including yet the vaccination program costs. Therefore, with vaccination, the net cost is usually estimated as the difference between the cost of intervention minus the savings from intervention. In this context, it is said that an intervention is cost-saving when the total cost of intervention are less than the total savings from intervention. One thing to keep in mind is also that all cost-saving interventions are also cost-effective, but not the other way around. Next slide, please. When it is cost-saving, it will be reflected in the value of this ratio, usually calculated in health economics, the incremental cost-effectiveness ratio. You may notice that the numerator is precisely the net cost just mentioned. Without elaborating more, let me just highlight that when the value of this ratio is less than 0, it means, for example, that preventing one herpes zoster case or one herpes zoster-related hospitalization will save us money. In other words, it would be more costly to do nothing, mainly because of the potential savings from adopting the vaccination program. Next slide, please. With this concept, now we could summarize the most important findings in these models. Based on 4 measures, the vaccination of the hematopoietic stem cell transplants group was found to be cost-saving by the CDC model. This is also reflected in the low number needed to vaccinate to avert a specific outcome, as you can see in the table. The cost per quality findings are generally supported with a simulation and sensitivity analysis. Look at the figure on the right-hand side. Specifically, 72% of these simulations, including the base case, came back being cost-saving, as seen by the dark dots within the green square in the lower right quadrant. Next slide, please. Similarly, in the GSK model, based on 2 measures, the vaccination of hematopoietic stem cell transplant group was also found to be cost-saving. Like CDC model, the simulation and sensitivity analysis of GSK model found their cost-saving results supported by the outcomes of their simulation analysis. As observed in the figure on the right-hand side, these simulations are in great part on the cost-saving area, the green dots and the green square in the lower right quadrant, or close to the low ones in the yellow square. A first takeaway, both models agree with being cost-saving the vaccination of hematopoietic stem cell transplant recipients, as shown by the cost per quality and cost per case report, and in the relatively low number needed to vaccinate to avert a herpes zoster case without or with PHN. Next slide, please. Yet it is important to understand what might be driving the variability in the simulations. Among many, this slide focuses on selected influential variables. Particularly influential are the epi and clinical variables, highlighted in red. In other words, any changes in either initial vaccine efficacy, herpes zoster incidence rate, or duration of immunocompromised status have a relatively or proportionally higher and increasing impact on the base case cost per quality value. If you prefer, you may review how different these parameters and assumptions are. Next slide, please. Regarding the cost effectiveness of additional immunocompromised populations or scenarios, the scenarios reported here are ordered by model and from cost saving to the most costly ones, should say the costliest ones. For most scenarios, the estimates are cost saving or reported to cost less than $100,000 per quality, except the one for the autoimmune and inflammatory diseases, with the cost per quality ranging from $150,000 to $200,000 per quality, depending on the model and specific assumptions. Next slide, please. Given the relatively large population size of people with autoimmune and inflammatory diseases, the working group considered important to explore more the health benefits and costs of vaccinating them. In this figure, the left-hand side summarizes the economic measures of cost per quality, and the x-axis shows the different levels of incidence for the autoimmune and inflammatory scenario. The solid line is calculated using the base case vaccine effectiveness for hematopoietic stem cell transplants clinical trial. Therefore, if healthcare costs are lower and incidence is relatively low, such as 11 cases per 1,000 person years, then the economic value of vaccinating this selected autoimmune and inflammatory disease group is relatively less favorable. The estimated one reported here is about $200,000 per quality. Next slide, please. In a similar fashion, and borrowing the threshold analysis from the GSK report, we may be able to corroborate the relatively high cost per quality in an implicit autoimmune and inflammatory scenario. If everything else remains equal from the hematopoietic stem cell transplant scenario, we could infer that for an incidence around 11 per 1,000 person years, see the vertical blue dotted line, which will be about 80% reduction in herpes zoster incidence, the cost per quality will become quite high. Please follow the orange curve increasing to the left, along which the increase in cost per quality, or correspondingly lower annual herpes zoster incidence rates. It is worth to note that GSK reported $150,000 per quality, $150,000 per quality, say, for an implicit scenario when assuming a starting age of 25 years, incidence of 10 per 1,000 person years, and 5 years duration of immunocompromised status, and a higher vaccine efficacy. Next slide, please. The main takeaway of this summary will be that both models concur in that the economic value of recombinant zoster vaccine immunization could be favorable. In other words, cost saving for hematopoietic stem cell transplant patients. Relatively higher herpes zoster incidence and higher healthcare costs combined with reasonable vaccine efficacy from clinical trials support these findings. Yet, the hematopoietic stem cell transplant recipients are relatively small population among all immunocompromised groups. For other immunocompromised groups, such as HIV or autoimmune inflammatory disease groups, the economic value of recombinant zoster vaccine immunization is less favorable relative to the hematopoietic stem cell transplant patients. This is due to the relatively lower risk of herpes zoster and lower healthcare costs. Some specific autoimmune and inflammatory conditions may have even the least favorable estimates, the fact that is heavily dependent on the underlying risk of herpes zoster. This is important considering the relatively large patient population size among all immunocompromised conditions. End of this summary. Thank you.
Thank you, Dr. Ortega-Sanchez. Really appreciate you helping us through with that very clear presentation, providing clear information on the two models. Would you like to open up this presentation for questions at this time? I'll invite any of our ACIP members or liaisons or ex officio members to please feel free to raise your hands. Dr. Lair.
A fairly simple question, and thank you for that wonderful presentation. This age group is 19 to 49. I'm just wondering where 18-year-olds went. I'm just thinking 18-year-olds are adults and I was wondering why they weren't included.
That is a good question. I don't have any specific answer to this. In fact, as you may see, for example, in slide number 12, when we show some specific comparisons across models, the age groups considered for the CDC were 3 groups, in fact. We split the 19 to 49 into 3 groups, 19 to 29, 30 to 39, 40 and to 49. Whereas in the GSK model, they put all of them together in one group, 19 to 49, with an average starting age of 35 years. The 19 years old, the 18 years old were not explicit in the models.
Dr. Anderson, maybe I'll ask you to chime in for state.
Yes, thank you. Dr. Lair, yes, for the policy question, the work group is focusing on 19 and up, given the concerns about the lower numbers of 19 and to 24-year-olds included in the clinical trials, and also just recognizing the implementation concerns for 18 and younger.
There is a microphone open. Can we mute? Thank you. Go ahead. Please go ahead, Dr. Anderson.
Yes, thank you. The work group is considering 19 and up for the policy question, given the lower numbers of patients who are included in the clinical trials for the 19 to 24, 18 to 24 age group, and also recognizing the implementation concerns for 18 and younger. So, thank you.
Thank you. Dr. Paling?
Yes, this is Kathy Paling. Thank you for a great presentation. I have another question. And if I understood the background information, there is no recommendation for persons 50 and older who are immunocompromised. And is that being considered by the work group? Thank you.
This is Dr. Anderson. Yes, we are considering 50 and up, but the work group did not consider that it was necessary to model 50 and up given the current age recommendations. So it's more looking at other outcomes for that age group.
Thank you. Are there any additional questions related to this particular presentation on the cost effectiveness? Dr. Paling.
Okay, I've got one more. Dr. Ortega-Sanchez, I wanted to make sure I understood the economic analyses correctly. So for the persons with autoimmune and inflammatory conditions, there was additional cost per quality, but the health outcomes were improved. Is that correct?
Yeah. I did a simplification of both analysis, and I tried to focus on what exactly was the more important variables. One is that the healthcare costs are lower for autoimmune and inflammatory disease related to herpes zoster I'm talking about, but the incidence is relatively low as well. And even though you may factor in the vaccine effectiveness that could be higher than the hematopoietic stem cell transplant group, still the cost per quality comes very high, mainly because this is driven mainly by the incidence of herpes zoster in these specific groups.
Thank you, Dr. Ortega-Sanchez. Oh, go ahead.
I hope this answers the question, yeah. The three groups that were considered were the systematic lupus erythematosus in the CDC model, rheumatoid arthritis, and psoriasis. And these three groups, the combined incidence rate is approximately 11.5 per 1,000 persons years.
Thank you.
Thank you. Are there any other additional questions? I just want to express my appreciation to our CDC Health Economics colleagues who have done such a wonderful job really helping pull together different models and helping us understand them in an efficient way, specifically related to decision making. I think this is a great example of a presentation that highlights the differences between these two independent models, but also gives us a lot of information that support decision making. So thank you again, Dr. Ortega-Sanchez, and we will move on to the next presentation.
Thank you, everybody.
I'm just going to confirm, is Dr. Masters?
Now, the next presentation will be regarding the preliminary ETR, Dr. Lee.
Okay, thank you. Go ahead, Dr. Anderson.
Okay, great. Thank you, Dr. Lee. I will now review the preliminary evidence to recommendations framework regarding use of recombinant zoster vaccine in immunocompromised adults and next steps. The policy question under consideration is, should adults 19 years of age and older who are or will be immunodeficient or immunosuppressed due to disease or therapy be recommended to receive 2 doses of recombinant zoster vaccine for the prevention of herpes zoster and its complications. Of note, this is including but not limited to the immunocompromised groups previously discussed by the work group and with ACIP. The components of the Evidence to Recommendations, or ETR, framework PICO question are shown on this slide. The population under consideration is immunocompromised, or IC, adults 19 years and older. The intervention is 2 doses of recombinant zoster vaccine, or RZV, at least 4 weeks apart. And the comparison is no vaccine. And here are the 8 outcomes identified by the work group as most important for the policy question. Prevention of herpes zoster and serious adverse events, or SAEs, were critical outcomes. And preventing post-herpetic neuralgia and zoster-related hospitalizations, immune-mediated disease, reactogenicity, graft versus host disease, and graft rejection were important outcomes. During today's presentation, I will provide an overview of each ETR domain regarding use of RZV in immunocompromised adults, including the available evidence and workgroup determinations. First, a review of the public health problem, which was previously presented during the June 2021 ACIP meeting. For this domain, the work group was to assess if herpes zoster in immunocompromised adults is of public health importance. As previously discussed, millions of persons in the United States are immunocompromised. In the 2013 National Health Interview Survey, approximately 7 million adults self-reported immune suppression. There are a total of approximately 3 million among stem cell transplant recipients, patients with hematologic malignancies, renal or solid organ transplant recipients, patients with solid tumor malignancies, and people living with HIV. In addition to these groups, there are approximately 22 million with more than 80 diverse autoimmune and/or inflammatory conditions, such as systemic lupus erythematosus, rheumatoid arthritis, and inflammatory bowel disease. These patients often have underlying immune defects, but generally are not considered frankly immunocompromised unless they are on immunosuppressing treatments. Importantly, an increasing proportion of immunocompromised patients are likely to be treated with immunosuppressive medications and therapies. And of note, zoster vaccine live was contraindicated for most immunocompromised patients. Herpes zoster is common in the general population. There were approximately 1 million cases of zoster per year in the United States during the pre-herpes zoster vaccine era. And as you can see in this figure, zoster rates increase with age, with incidence rates ranging from about 2 to 9 per 1,000 persons. As previously noted, the immunocompromised population at higher risk for zoster is substantial, but estimating burden of disease requires a clear understanding of zoster incidence and severity in these groups. A systematic literature review regarding the risk of zoster in groups 1 through 5 was recently conducted. It was noted that the median zoster incidence estimates for these immunocompromised groups exceeded those reported for immunocompetent adults 50 years and older, and this is depicted in the figure on the right. The incidence rate of zoster ranged between 9 and 95 per 1,000 person years. As you can see, there was variation in study estimates for the cumulative incidence and the incidence of zoster within each group and between groups. Ultimately, risk within each condition varies due to the underlying disease and therapies received. For stem cell transplant recipients, zoster risk varies depending on the type of transplant received and complications such as graft versus host disease, both of which may affect the type and timing of prophylaxis received. For solid organ transplant recipients, zoster risk correlates with the intensity of immunosuppression, with the highest risk for heart and lung transplant recipients, followed by kidney and liver. Solid organ transplant patients are on lifelong immunosuppressants, while stem cell transplant recipients may be able to discontinue their use, so risk may vary over time among populations. In the systematic review, it was also noted that zoster complications and severe disease were increased in immunocompromised populations. However, the data were insufficient to assess risk by group. Regarding available data, for post-herpetic neuralgia, or PHN, approximately 6 to 10% of immunocompromised patients experience PHN versus about 4% overall in administrative claims databases. And between 6 and 45% experience PHN across immunocompromising conditions and studies. For disseminated zoster, approximately 3% of immunocompromised patients experience disseminated zoster, but it is exceedingly uncommon in healthy persons. and between 10 and 17% mortality has been associated with disseminated zoster among renal transplant recipients. Finally, 8% of stem cell transplant recipients with zoster are hospitalized versus less than about 1% of overall Medicare beneficiaries with zoster. As you can see, better evidence of the incidence of zoster complications and severity in immunocompromised populations are needed to inform economic and zoster vaccine policy analyses. Regarding the risk of zoster in Group 6, included here is a figure and brief summary of findings from a study evaluating the risk of zoster in autoimmune and inflammatory diseases. In this study, the authors determined that there is an approximately 2 to 4-fold higher risk of zoster in patients with autoimmune and inflammatory conditions than in healthy individuals. It was noted that the risks varied across conditions and by age groups, and age-standardized zoster incidence rates varied, with the highest rates in patients with systemic lupus erythematosus, or SLE, inflammatory bowel disease, or IBD, and rheumatoid arthritis, or RA. Another recent study identified similar results, with an approximately 1.5-fold higher risk of zoster for unvaccinated Medicare beneficiaries with AI conditions versus those who were not immunocompromised. As previously noted, for some autoimmune conditions, such as SLE, IBD, and RA, the risk of zoster is about 2 to 4-fold higher. And importantly, age-specific incidence rates among 21 to 50-year-olds can be comparable to or substantially higher than corresponding rates in healthy adults greater than 60 years of age. The impact of immunosuppressive treatments is another consideration for these patients. The standard of care is for patients to be on one or more immunocompromising drugs, the duration of which could be months, years, or lifelong. In addition, it is not possible to define high-risk subgroups based on anticipated drug treatments, including disease-modifying anti-rheumatic drugs, glucocorticoids, and biologics, since they are very different from condition to condition and even over time for individual patients based on their response, tolerability, and other factors. Important points from work group discussions include that immunocompromised populations are very heterogeneous, both across and within groups and among individuals over time. The risk of zoster and its complications is generally higher in immunocompromised populations, although there is variability across and within groups. It is not feasible to define every possible immunocompromising condition and medication combination, and that is important to consider broad recommendations and provider guidance for immunocompromised populations. The work group has extensively reviewed these and other findings and concluded that yes, zoster and its complications in immunocompromised adults is of public health importance. Now moving on to benefits and harms. First, we will discuss the available evidence regarding how substantial the desirable anticipated effects of RZV in immunocompromised adults are for each main outcome. Then we will discuss the available evidence regarding how substantial the undesirable anticipated effects are for each main outcome. And we will then summarize the work group's interpretation regarding whether the desirable effects outweigh the undesirable effects. Here we provide the information sources and inclusion and exclusion criteria used for the systematic review. I will not go into this in full detail, but the slide is included for your reference. Of note, for benefits, the population was subsetted to those who received 2 doses of RZV, while the harms evaluated all who received at least 1 dose of RZV. This flow diagram shows the evidence retrieval for all records included in our evidence synthesis. I will not go into full detail here, but this slide is also included for your reference. There were a total of 19 studies included in our evidence synthesis. Here you can see the 9 studies included in the review of evidence and grade analysis, since they included a comparator group. There were 7 randomized controlled trials and 2 cohort studies across several immunocompromised populations, including patients with hematologic malignancies, renal transplant recipients, solid tumor patients, autologous hematopoietic stem cell transplant recipients, patients living with HIV, patients with immune-mediated diseases, patients with inflammatory bowel disease, and Medicare beneficiaries with immunocompromised and autoimmune conditions. Here we list the outcomes included in the overall grade analysis. The The highlighted rows are the critical outcomes that will be presented during today's session, including prevention of herpes zoster and serious adverse events, or SAEs. We will also discuss one of the important outcomes, graft rejection. The remaining important outcomes are addressed in supplemental slides. For outcome 1, prevent herpes zoster, using the efficacy population, the vaccine effectiveness estimates range from 68% to 100%. Estimates were generally higher in younger adults within a population and lower for autologous stem cell transplant recipients. Of note, VE in immunocompetent adults is about 90% to 97% depending on age. The two peer-reviewed cohort studies are shown here, with VE reported for Izureta et al. Among autoimmune and immunocompromised Medicare beneficiaries of 68% and 64.1% respectively. Khan et al. Looked at VA patients with inflammatory bowel disease and found adjusted hazard ratios of 0.41 for those over 60 years who were on non-steroid users and 0.34% for those who were steroid users, and a hazard ratio of 0 for the 50 to 60-year-old group since no cases were reported. Using the efficacy population for studies reporting immunogenicity, this table shows the vaccine response rate for both humoral and cell-mediated immunity across the 6 included randomized controlled trials. These studies show that there was a vaccine response. Starting with humoral immunity, response rates ranged from a low of 65.4% to a high of 96.2% at 1 month after the last dose. This somewhat decreased at the 12-month evaluation mark, with response rates ranging from a low of 51.5% to a high of 91.7%. Placebo response rates were very low, from 0 to 6.4%, corresponding to adjusted geometric mean ratios ranging from 14 to 42.2 for 1 month after the second dose and 8.81 at 12 months after the second dose. For cell-mediated immunity, the VRRs range from a low of 50% to a high of 93% at 1 month after the last dose, decreasing to a low of 17.6% and a high of 66.7% 12 months after the last dose. Again, placebo rates were low. Here's the grade evidence table for outcome 1, prevent herpes zoster. For the RCTs, the evidence type started at 1. There was no serious risk of bias identified and no concerns for inconsistency or imprecision. The body of evidence was downgraded for indirectness due to not comprising data on all relevant populations under the recommendation. The VE estimates ranged from 68.2 to 90.5%, with an overall certainty of type 2 or moderate certainty. For RCTs containing immunogenicity data, the risk of bias was not serious, and there were no concerns with inconsistency or imprecision. However, the body of evidence was doubly downgraded for indirectness due to both studies not comprising the range of populations under consideration for the outcome and also a surrogate outcome. Humoral adjusted GMRs range from 14 to 42.2, and the CMI adjusted GMR ranged from 9.94 to 17.26, measured at 1 month after vaccination. This evidence was graded type 3, or low certainty. For cohort data, the evidence type starts at 3. There were no serious concerns with risk of bias, inconsistency, or imprecision, but the studies were downgraded due to indirectness and upgraded due to a strong association observed among those over 50 years of age. The hazard ratio for those with 2 doses of RZV compared with placebo was 0 for 50 to 60-year-olds and 0.39 for those over 60. The evidence was graded type 3, or low certainty. For outcome 4, serious adverse events, 7 randomized studies evaluated multiple immunocompromised populations. Overall, SAEs were fairly balanced between the vaccine and placebo groups. Using the harms population, or those who received at least 1 dose of RZV, there was a risk ratio of SAEs ranging from 0.79 to 1.99. It is important to note that this population is significantly ill, and thus the high proportion of SAEs in both the vaccine and placebo group are not unexpected. However, the SAEs related to vaccination were much less common, ranging from 0.33 to 1.6% in the vaccine group and 0.36 to 0.76% in the placebo group. The grade evidence table for outcome 4, serious adverse events, is shown here. The evidence type started at 1, and the body of evidence was downgraded only for indirectness. The proportions of RZV and placebo recipients experiencing SAE are noted in the table, with risk ratios ranging from 0.79 to 1.99, but generally representing a similar proportion of SAEs in both groups. The body of evidence was graded with a certainty of type 2, or moderate certainty. For outcome 7, graft rejection, one study was included. This study looked at renal transplant patients receiving daily immunosuppression with stable renal function, free of allograft rejection or multiple organ transplants, or potential immune-mediated diseases. There were 4 cases of graft rejection in the vaccine group, or 3%, and 7 in the placebo group, or 5.3%, for a calculated risk ratio of 0.57. There were also 3 studies with no comparator that were included in our evidence synthesis, but not formally included in the grade analysis. Bargash and Louile found no evidence of graft rejection, while Herzl found 6.1% of participants experienced rejection among a population of lung transplant patients. Of note, these rejection episodes were classified as unrelated to vaccination. Here's the evidence table for outcome 7, graft rejection. As an RCT, the study began at an evidence level of 1 and was downgraded for indirectness due to only including renal transplant patients and for imprecision due to small counts of included cases. The final evidence type was type 3, or low certainty. I will now briefly summarize the grade results, going through each outcome and major findings. The details for the outcomes not covered in this presentation are available in the supplemental slides for your reference. For benefits, the body of evidence shows relatively high vaccine effectiveness across these heterogeneous immunocompromised populations, ranging from 68.2 to 90.5%. For preventing postherpetic neuralgia and Zoster-related hospitalization, there was little evidence, just 1 study, but reported VE was 89% and 85% respectively. For harms, serious adverse events were common and balanced in both vaccine and placebo groups, with risk ratios ranging from 0.79 to 1.99, and SAEs attributed to vaccination were rare. Immune-mediated diseases were not shown to be increased for those in the RZV group. There was little data on graft versus host disease and graft rejection, with 1 RCT each showing no increased risk of rejection. Finally, RZV was noted to be reactogenic with increased reported local and systemic reactions in the RZV group. Of note, limited data for some harms outcomes highlights the need for additional research as well as provider counseling for these patients. For example, there may be counseling regarding appropriate timing of vaccination for some immunocompromised patients. Upon review of these data, the work group concluded that the desirable anticipated effects of RZV in immunocompromised adults are large, and that the undesirable anticipated effects are small. Overall, the work group concluded that the desirable effects outweighed the undesirable effects, which favors the intervention of RZV, 2 doses at least 4 weeks apart. Now on to values. First, does the target population, or immunocompromised adults, feel that the desirable effects of RZV are large relative to the undesirable effects? And then, is there important uncertainty about or variability in how much immunocompromised adults value the main outcomes? There's limited published data, but in general, zoster vaccination is increasing, and RZV series completion rates are high. Although there is currently no ACIP recommendation, immunocompromised patients recognize the increased risk of zoster, and many have already received RZV. As noted in a large study of Medicare data where nearly 1 million patients met the study definitions of autoimmune and immunocompromised and received RZV. In summary, many immunocompromised patients desire the ability to receive RZV to prevent zoster and its complications. In fact, many are already pursuing vaccination with RZV as part of regular care, as shown in the Izziaretta et al. Medicare analysis. We anticipate that more immunocompromised patients would pursue vaccination for zoster if recommended by ACIP and their provider. Upon review of these data, the work group concluded that probably yes, immunocompromised adults feel that the desirable effects of RSV vaccination are large relative to the undesirable effects, and that there is probably not important uncertainty or variability in how much immunocompromised adults value the main outcomes. Now moving on to acceptability. Specifically, is vaccination with RSV acceptable to key stakeholders working with immunocompromised adults? There are limited published data. However, primary care physicians' perspectives were captured in a recent University of Colorado Denver Knowledge, Attitudes, and Practices, or CAP survey. Important points from work group discussions are again highlighted here, including the heterogeneity of immunocompromised populations, the reality that it is not feasible to define every possible immunocompromising condition and therapy combination, and that an age-based recommendation is preferred since this will provide the most actionable guidance for clinicians and patients. The objectives of the noted survey were to assess, among primary care physicians serving adults regarding RSV, their current practices, attitudes, knowledge, and barriers to recommending RSV, and the likelihood of recommending RSV to immunocompromised patients among physicians who had not previously recommended the vaccine to these patients. Physicians in existing Vaccine Policy Collaborative Initiative, or VPCI, Sentinel networks were surveyed, and family physician, or FP, and general internist, or GMI, results are combined with any differences highlighted. Regarding physician strength of recommendation for RSV in different types of patients 50 years and older, you can see here the recommendations for healthy adults, adults anticipating a bone marrow or solid organ transplant, and adults on low-dose methotrexate are consistent with current ACIP recommendations, with 70 to 96% strongly recommending or recommending but not strongly RSV. Among patients without an ACIP recommendation, you can see that the strength of recommendation for RSV varies considerably by age and health status, with 67% strongly recommending or recommending but not strongly RSV for adults 50 years and older with HIV, to 42% strongly recommending or recommending but not strongly RSV for adults 50 years and older, receiving immunosuppressive therapy for a bone marrow or solid organ transplant. Of note, 27 to 42% of respondents noted they defer to a subspecialist for these immunocompromised populations 50 years and older. For adults 18 to 49 years old with an immunocompromising condition, 31% of respondents noted strongly recommending or recommending but not strongly RSV, while only 4% noted strongly recommending or recommending but not strongly RSV for healthy adults 18 to 49 years old. Among physicians who had not recommended RSV to immunocompromised patients, the likelihood of recommending RSV to a range of immunocompromised patients 18 years of age and older was very likely for 40% to 48% of respondents. Percentages were also similar for somewhat likely, somewhat unlikely, and very unlikely responses. Since these responses were based on how likely a respondent would be to recommend RSV to a immunocompromised patient within the first 6 months of an approval and without input from a subspecialist, these results highlight the importance of provider guidance for vaccination of immunocompromised patients. In summary, given highly specialized care and increased Zoster risk among immunocompromised populations, the work group noted that vaccination is favored if there are no safety concerns. As previously noted, additional safety data is a research need. However, the work group considered currently available evidence acceptable. Importantly, despite the lack of a recommendation for ACIP, many physicians are recommending RSV to patients with immunocompromised conditions. Of note, physicians need more direction on which patients are eligible for RSV, including a substantial minority who would be unlikely to recommend RSV to various immunocompromised patients, even if it were licensed, recommended, and covered by insurance for them without input from a subspecialist. Overall, the work group anticipates that acceptability of RSV vaccination in immunocompromised adults would increase with FDA approval and ACIP recommendation. Upon review of these data, the work group concluded that yes, use of RSV in immunocompromised adults is acceptable to key stakeholders. Moving on to feasibility. Specifically, is RZV in immunocompromised adults feasible to implement? There are also limited data that are published for this domain, other than some information from the previously noted CAP survey. Again, important points that were previously noted from our workgroup discussions are included here. To briefly summarize workgroup discussions, delivery of RZV is complicated by delivery at different locations. As previously noted, physicians need more direction on which of their patients are eligible for RZV, and it is also anticipated that identification of immunocompromised patients, for example based on immunosuppressive medications, and standing orders will be concerns in the pharmacy setting. Although implementation is addressed at the jurisdiction and provider levels, the workgroup noted that decision support guidance, for example for electronic health records and immunization registries, would be helpful. The workgroup concluded that yes, use of RZV in immunocompromised adults is feasible to implement. Moving on to resource use. Specifically, is RZV in immunocompromised adults a reasonable and efficient allocation of resources? As noted in Dr. Ortega-Sanchez's previous presentation, summarizing the economics of vaccinating immunocompromised 19 to 49-year-old adults against zoster in the U.S., for hematopoietic stem cell transplant recipients, the base case, vaccination with RZV was cost-saving in both the GSK and CDC models. Some scenarios were also cost-saving or ranged in dollars per quality of $10,000 to $208,000, depending on the scenario. As noted by Dr. Ortega-Sanchez regarding base case hematopoietic stem cell transplant patients, the economic value of RZV appears to be favorable or cost-saving. This is influenced by higher zoster incidence and zoster-related healthcare cost and reasonable VE. Of note, the base case represents a smaller proportion of the immunocompromised patient population. For scenarios focused on other immunocompromised patient groups, such as patients living with HIV or patients with autoimmune and inflammatory conditions, the economic value of RZV vaccination is less favorable relative to stem cell transplant patients, given their lower risk of zoster, severe outcomes, and lower healthcare costs. Of note, some autoimmune and inflammatory conditions may have the least favorable estimates of RZV use, depending on the underlying risk of zoster. And importantly, patients with autoimmune and inflammatory conditions represent a larger proportion of the immunocompromised patient population. Overall, given the highly specialized care and resources typically invested for the base case and other immunocompromised populations, the workgroup did not consider cost-effectiveness assessments to be a main driver for decision-making. Upon review of these data, the workgroup therefore concluded that yes, use of RZV in immunocompromised adults is a reasonable and efficient allocation of resources. Finally, moving on to equity. Specifically, what would be the impact of RZV use in immunocompromised adults on health equity? The National Health Interview Survey captures zoster vaccination data, including data for zoster vaccine live and recombinant zoster vaccine. Overall, in 2018, zoster vaccination coverage among adults 50 years and older and 60 years and older was 4.1% and 34.5% respectively. White adults 50 years and older and 60 years and older had higher coverage compared with Blacks, Hispanics, and Asians. In an analysis using 2010 to 2019 NHIS data, in general, race, ethnicity, household income, education level, and health insurance type were significantly associated with receipt of zoster vaccinations among adults 65 years and older. The workgroup anticipates an ACIP recommendation would increase access overall, since a recommendation increases the scope of the population eligible to be vaccinated and ensures coverage under ACA. However, there will likely still be challenges with uptake, given the previously noted race, ethnicity, household income, education level, and insurance disparities, and potential out-of-pocket costs. Upon review of these data, the workgroup concluded that health equity would probably be increased. And now for the overall ETR summary. Regarding the noted ETR domains, the workgroup determined that herpes zoster in immunocompromised adults is of public health importance. The desirable anticipated effects of RZV use in immunocompromised adults are large, and the undesirable effects are small, which favors the intervention. Immunocompromised adults probably feel the desirable effects of vaccination with RZV are large relative to the undesirable effects, and that there is probably not important uncertainty or variability in how patients value these outcomes. Use of RZV in immunocompromised adults is acceptable to key stakeholders, feasible to implement, and a reasonable and efficient allocation of resources. And health equity would probably be increased. The workgroup therefore concluded that the desirable consequences of vaccinating immunocompromised adults with RZV clearly outweighed the undesirable consequences in most settings, and ultimately would recommend the intervention. I will now address special considerations for use of RZV in immunocompromised adults and next steps. RZV package insert contraindications, warnings, and precautions are summarized here. Of note, RZV is contraindicated for patients with a history of severe allergic reaction to any component of the vaccine or after a previous dose. Warnings and precautions include an increased risk of Guillain-Barré syndrome, or GBS, which was observed during the 42 days following vaccination with Shingrix in a post-marketing observational study that was presented to ACIP in February 2021, and syncope. The workgroup discussed several special considerations for the potential use of RZV in immunocompromised adults. Regarding pregnancy, although the workgroup would not recommend pregnancy testing prior to vaccination, in the case of a known pregnancy, the workgroup would note to delay vaccination given the lack of data. Regarding breastfeeding, similar to most other vaccination recommendations, the workgroup would not recommend delaying vaccination. Regarding individuals with a history of GBS, the workgroup noted that the RZV VIS risks of vaccine reaction section should be updated per the FDA package insert warning, and that providers and patients should discuss the potential risk. Regarding individuals who have received the Varicella vaccine series, laboratory testing would not be recommended to confirm vaccine-induced immunity. And for individuals with no history of varicella or varicella vaccine, RZV is not indicated for the prevention of primary varicella varicella infection. However, laboratory testing would not be recommended to confirm a patient is naive. Of note, there are limited safety data for use of RZV in these patients. For next steps, we look forward to today's discussion on the preliminary ETR and special considerations for use of RZV in immunocompromised adults. The herpes zoster workgroup will then discuss any ACIP feedback at subsequent workgroup meetings and finalize the ETR. And we anticipate presenting the final ETR and holding a vote at a future ACIP meeting. I would like to acknowledge the many CDC staff, herpes zoster workgroup members, grade consultants, and University of Colorado Denver Vaccine Policy Collaborative Initiative staff for their contributions to this work. Thank you for your time and attention, and I'll now turn things back over to Dr. Lee for our discussion.
Thank you, Dr. Anderson. That very thorough presentation. This presentation is now open for questions. Dr. Long? And there's, I wonder if there's a mic open at ACIP or CDC. There's an echo. Thank you. Dr. Long.
Yes, thanks so much. You may have said it and I may have missed it, but the question is, what this concerned is, we're talking about vaccinating 19 to 49-year-olds. And those 40 and under almost certainly would not have had chickenpox, but would have had only vaccine. So the question is, in all of your reported incidences of hospitalization and relative risk, hospitalization, disseminated disease, fatality, the two questions are those in this age group? And are those presumably all after vaccine varicella, and they're therefore vaccine varicella zoster? Or are they complications that were derived from older data or older people in which zoster that follows natural infection, has a more severe course? So that's the first question. And then the other one was the number of immunocompromised people that you gave us, the 7 million and the 22 million. Was that people 19 to 49? So the questions are about the complications of zoster by age and the number of immunocompromised. And are you presuming now that this is at least 40 and under all vaccine varicella related zoster?
Yes, thank you for those questions, Dr. Long. Yes, the varicella vaccinated cohort is just now reaching about their mid-20s or so. And so the data are still to be determined in terms of how severe their outcomes are compared to the individuals who experienced natural infection. In the pediatric population, there's some evidence that the incidence is lower, but it does seem to be that the severity is pretty similar. But that is pediatric data, and we have yet to collect more data for the older individuals who are just now, as we said, reaching that cohort. For immunocompromised people, yes, those figures are general studies. I would have to look back to look at a breakdown for the age groups and those.
So I must have a faulty memory. I'm sorry, I'm getting a lot of feedback. The varicella vaccine, wasn't that in the 80s? Aren't these people now not 20 but 40? It was certainly well before pneumococcal vaccines.
Yes, that recommendation was in 95, 96.
For
varicella vaccine? Yes.
At 1 year's of age?
Yes, and then the first dose, and then in 2006, there was a recommendation for 2-dose series.
Okay, so that's and I remember. I didn't quite understand what you said about the rates of dissemination, complication, and death. You don't know whether that was based on zoster following infection or zoster following immunization.
I'm sorry, could you hear? I'm sorry, my mic might not have been on. Those studies would be expected to be related to natural infection?
Well, does the work group think that's appropriate?
Maybe Dr. Cotton, do you want to comment briefly?
Sure. Yes, we did think that was related to natural disease, not to prior vaccine exposure. And as someone who practices with immunocompromised patients, we do see a lot of significant disease in this population, including disseminated disease, including life-threatening disease such as encephalitis, pneumonitis, and potentially devastating outcomes. That was covered in one of the earlier slides with the rates were shown in specifically kidney transplant recipients, but other populations as well.
But in people who had natural varicella, not who had vaccine varicella.
Yes. Dr. Long, it's interesting that in reviewing the data, I had some similar thoughts about what has the impact of varicella vaccine been. Remembering that in the beginning, it was recommended that they receive 1 dose of vaccine, and then there was an updated recommendation for 2 doses of varicella vaccine.
Right.
And it's interesting. It does look like we are seeing what seems to be natural disease-related zoster in this somewhat younger cohort. It looks as though maybe there was breakthrough wild-type disease due to somewhat decreased vaccine efficacy. It may have been subclinical. There's basically more what I would call wild-type zoster than we might have anticipated. But it is an interesting question, and I imagine that as time goes by and as we have more robust primary varicella vaccination with 2 doses, that we may see less zoster in this younger population. But for now, I was impressed by the data, and then as someone who takes care of people in their 20s, 30s, and 40s who are immunocompromised, that they do have significant rates of zoster.
Thank you. Thank you. We'll move on to Dr. Paling.
Yes, thank you for a great presentation. I wanted to ask a little bit about health equity. And one of the things that I believe I understood from the presentation was that multiple locations of delivery may help with the health equity, such as pharmacies. If we are talking about these additional locations for vaccines, the communication so that the primary care providers and subspecialists know that. And so I wanted to get your thoughts from the work group about the importance of a vaccine registry for adults. Thank you.
Dr. Anderson?
The work group hasn't specifically discussed a vaccine registry, but we've certainly discussed the importance, as you said, of provider and patient communication materials to make it very clear which patients should be considered for vaccination with RZV. As we talked about, these immunocompromised populations are very heterogeneous, and considering that a large percentage of patients may receive RZV in a pharmacy setting, we definitely want to make sure that communication materials are clear and available for providers and patients so that they understand which patients should be considered for vaccination. And so there will be multiple, the MMWR policy note, other communications materials that we can have on our website, as well as a future R&R that will hopefully make those clarifications. Does that address your question?
Yes, I just also am, that's a very important point. I think the other thing is, how does the vaccine status information be transferred so that the primary care physician and the subspecialist knows what happens in any of these settings? Because it seems like right now we're dependent on the patient to tell us.
Thank you. That's Dr. Paling, that's a critical point. I'm actually going to, perhaps at the end of the session, ask our colleagues from the Immunization Registry to comment perhaps on, how many states are inputting zoster vaccination for adults into their immunization registries. But right now, I'll call on Dr. Sanchez.
Thank you, Grace. No, that's really good presentation. But I just had a minor question. The recommendation for the immunocompromised individuals are for 4 weeks of I think it's 4 weeks. And isn't the second dose in adults 2 months? Just clarification.
Yes, thank you. Yes, the current recommendation is for 2 to 6 months after the first dose. The FDA, when they recently approved the use of the vaccine in 18 and up who are known to have an immunosuppressive disease or therapy, they also included that a change that would allow vaccination 4 weeks after the first dose, if if that would be unfavorable for patients. So, and then the reason we use that wording in the grade analysis was just that when we were going through and assessing the available evidence, that was one of our criteria, that the vaccines, the doses had to be given at least 4 weeks apart. Most of them were giving, at least that, and if not, on the typical schedule.
Thank you.
You're welcome.
Thank you. Dr. Daly.
Yeah, I also had a question about health equity. So I appreciate Dr. Paling's question, and mine's of a little bit different sort. But, I've struggled with this domain in ETR, and I feel like we're often speculating on. So when we have a new population or a new indication for a vaccine, we struggle with how to judge how that will impact health equity. But I'm just concerned that in circumstances like that, the environment that causes the health equity is no different. And so I have trouble believing that a new indication or a new population is not going to encounter all the same inequalities that the sort of prior recommendations encounter. So I guess that's a comment. And I guess the question would be, do we know anything about what explains the inequalities that exist today in zoster vaccination coverage, and what can we do proactively to reduce the inequality to the extent possible? Over.
Yes, thank you. In the work group, when we discussed the health equity domain, we certainly talked about the challenges that there would be, to be able to monitor equity over time for this domain. And we did talk about how, as has been recommended for some of the other vaccines recently, like especially talking about COVID vaccine equity, the importance of that being local, or a more feasible reality of it being monitored more at the local level. So that is something that the work group discussed, because it's challenging at the federal level with the available data to be able to really drill down and appreciate those nuances. But as is on this slide here, as you'll note, so in general, what's been seen is that race, ethnicity, so then white being more likely to be vaccinated than other race and ethnicities, higher household income, higher education level, and health insurance type, for example, like Medicare Advantage, those individuals are significantly associated to have a higher receipt of zoster vaccinations. And so definitely agree that it will be challenging to monitor this domain, and ways to try to impact that would hopefully be through communications and other materials for providers and patients, but agree that this will be a challenging domain to monitor moving forward. Would certainly recommend, as we talked about in the work group, would certainly list this as something that would be a strong and an important consideration for local implementation.
Thank you. And, as a work group member, I just wanted to chime in really quickly on this point, which is to say that, currently we know that people are getting the vaccine, but it's not currently recommended by ACIP. And so my concern would be that perhaps some of these individuals are already paying out of pocket, whereas with a full ACIP recommendation, we could ensure that coverage and access would be more equitable, recognizing, again, that we still have uninsured and underinsured populations where that needs to be addressed, but at least to a certain extent, it would broaden access and coverage from that perspective. Okay, we'll go on to Dr. Lair.
Thank you. One comment and one question. The comment's fairly simple. I'd suggest that the recommendation include 18-year-olds. It just seems odd that you start at 19 instead of 18, and just brings up a little false nudge to me. My question is, with the autoimmune and inflammatory conditions, is there any data that can separate out the underlying condition versus the medications that they're on? So both from a voting member and a practical practitioner, I have a sense of, am I actually giving them because they have lupus or because they're on methotrexate that they would be recommended, or is it both, or you just don't have the data? Over.
Thank you, Dr. Lair. Yes, we appreciate your suggestion. As of note, the adult immunization schedule starts at 19 years of age, and so that is part of that choice for the policy question focusing on 19. And regarding your other question for autoimmune and inflammatory conditions and medications, yes, the data is challenging. There are studies that address both these conditions and the medications, but it is difficult to tease out the influence of these on zoster risk. And so, that's just part of where the work group ultimately had discussed that it's just really not feasible or practical to really address every condition and medication or therapy combination. So that, again, highlights the importance of, some very thorough clinical guidelines or guidance for providers for, that work with immunocompromised patients and for the patients themselves.
Thank you. And actually, Dr. Cotton, would you like to respond?
I just wanted to say that to Dr. Lair that it's a good question. Both the condition and the immunosuppressive medications would increase the risk of zoster. So from my perspective as a clinician, I would want to provide vaccine for both of those situations, and obviously in the same patient, it's still the same indication. So that wouldn't really change things. It would be way too complicated if we tried to break it down into every, and it would be impossible to break it down into every combination. So that's why this is sort of an overall guidance. I hope that makes sense.
Thank you. Ms. Hayes.
Yes, Carol Hayes with the American College of Nurse Midwives. I have a question about health equity. I know of 2 individuals over the age of 65 on Medicare that could not afford to get this because their Medicare Part D did not cover it and the vaccine cost $200 and therefore they are unvaccinated. And I'm curious if we have any data on the percent of Medicare Advantage plans that don't cover this vaccine.
We do not have that data, but I could certainly take that back and look into that. Certainly when we were in this 2010 to 2019 study that's highlighted on this slide, that was one of the things. Individuals with Medicare Advantage were, significantly associated for receipt of Zoster vaccinations, but we can certainly look into whether or not we can determine the percentage that would not cover RZV. Thank you.
This is Melinda Wharton. I think the issue with Medicare is Medicare Part D rather than Medicare Advantage.
Thank you. And just, speaks to the gaps that we have in the U.S. in terms of insurance coverage and specifically how we need to think about vaccine programs that do address equity. Dr. Goldman.
Thank you. I'll be brief because Dr. Long definitely touched upon the first question, but I did want to follow up on the previously vaccinated as well as the concept of checking antibodies or not. And since this is not indicated for primary prevention, is there any harm, though, if a patient does receive the RZV when they have never had varicella or the vaccine? Is there any data? And to follow up on that, is there any consideration for a universal age-based recommendation for RZV at 19, or is it simply a matter of cost effectiveness?
Thank you for that question. Yes, regarding individuals without a history of varicella or varicella vaccine, there are limited safety data. There's one study that was looking at VZV negative individuals who received RZV, and there were no significant safety findings for that study. It's one of the studies that's didn't have a comparator group, so therefore it was not included in the grade, but was included in our evidence synthesis. But there is very limited safety data. And then for your next question, let's see, trying to make sure I've got that straight. Oh, in terms of the laboratory testing, the work group has discussed that there are challenges with laboratory testing and the reliability of the results. So another reason to not require laboratory testing prior to vaccination. And then the final question, the current discussion is focused on 19 and up who are considered at increased risk of Zoster. To my knowledge, there aren't currently discussions of whether or not to consider RZV for healthy adults 19 and older.
Thank you. Ms. McNally.
Dr. Anderson, could you briefly address the issue of co-administration for this vaccine?
Yes, RZV can be co-administered with other adult vaccinations. There's currently no concern with that.
Okay. Ms. McNally, do you have any other questions?
No, I don't have any other questions. Thank you.
Okay, thank you. Dr. Long, I actually wanted to see, I was going to check to see if Ms. Coyle from the American Immunization Registry Association could just make a couple of comments about Zoster vaccine, especially if administered in pharmacy settings.
Sure. Thank you, Dr. Lee. I appreciate the question. So I'm happy to report that all of the immunization information systems out there can actually accept adult data. So that's a very positive thing. Back at the beginning of the year, I'm aware of at least 2 IISs that were in the process of transitioning to new systems when COVID vaccines rolled out. And so I know in those situations, they had to prioritize accepting COVID vaccines before they could accept other adult vaccines. It's important to remember that, back in 2019, we already had about 60% of adults in an IIS with a record. So we anticipate that number has increased significantly over the past 9 months. And then we just tested 57 IISs to find out if they could actually accept a Zoster vaccine. And all 57 came back saying, yes, they can accept it. That means they can actually take the data in, but what we can't control for is whether or not providers are actually submitting that data. So in the instance of a pharmacy system, most of our pharmacies are connected to the local IIS and are submitting that information. So that's a very positive thing. And I anticipate this will only continue to get better over the coming years.
Thank you so much. Dr. Long.
Yes, it's about I think, overly cautionary note about breastfeeding. And I think it's a burden on physicians to discuss risk and benefit, and it is also confusing because of the prior live virus vaccine. This is not any different from influenza or Tdap or other vaccines, inactivated vaccines that that lactating women get. So I don't think that absence of data here should lead to such a cautionary tale, because it will be confusing to physicians.
Oh, thank you, Dr. Long. Actually, just to clarify, the work group had discussed that for pregnancy, that they would not recommend pregnancy testing prior to vaccination, but if there was a known pregnancy, to delay vaccination given the lack of data. But for breastfeeding, similar to most other vaccine recommendations, the work group discussed that they would not recommend delaying vaccination during breastfeeding.
I just say you want to look at the wording provided for us about breastfeeding. It was very negative.
Oh, I see. Okay, so I see what you're saying. So just to make sure, thank you. We can make a note to revise that language.
Thank you. Are there any additional questions? Seeing none, I'm going to start, ask you to mute. And then thank our presenters. And the committee will now recess until, let's say, 45 after the hour. So you have a 8-minute break. Thank you very much, everybody.